aqueous misdirection is a serious but rare entity that occurs typically after incisional surgery for angle closure disease. It is characterized by shallow peripheral and central anterior chamber with raised or sometimes normal intraocular pressure in the presence of patent peripheral iridotomy. The most accepted pathogenesis is that an abnormal anatomic relationship exists between the ciliary body, lens, and anterior hyaloid, causing diversion of fluid into the posterior segment. Aqueous pockets within the vitreous raises intraocular pressure and thereby exerts a force on the anterior hyaloid that causes a forward displacement of the lens iris diaphragm, recognized clinically as a uniformly shallow AC. Pharmacotherapy is typically the first-line treatment involving administration of cycloplegics, aqueous suppressants, and hyperosmotics are administered to facilitate lowering of intraocular pressure. In cases refractory to medical management, YAG laser hyaloidotomy may be attempted, as seen here in one of the cases, which led to some deepening of the anterior chamber. However, nearly half the patients eventually require surgical management. Aim of the surgery is to convert the eye into a unicameral chamber. Up until now, the standard surgical procedure of choice is pars plana vitrectomy with lensectomy if the patient is phakic. But recurrence is not unknown. We describe a technique called Irido-Zonulo-Hyaloido-Vitrectomy for management of aqueous misdirection that can be performed by an anterior segment surgeon, eliminating dependence on a posterior segment surgeon. This procedure can be undertaken via corneal, ostial, or pars plana route. Here in this video, we shall demonstrate all three routes. In the first case, the patient had undergone multiple filtering surgery in angle closure glaucoma and developed aqueous misdirection for which pars plana vitrectomy was done. She presented to me 6 weeks later with flat anterior chamber, previous tube barely visible, early signs of corneal decompensation, patent PI, pigmented pupillary membrane, and count fingers vision with high intraocular pressure on anti-glaucoma medication and atropine. She first underwent a YAG hyaloidotomy through pre-existing surgical iridectomy, following which a slit AC formed. In this case, she underwent Zonulo-Hyaloido-Vitrectomy via the corneal route and through a pre-existing surgical iridectomy. Preoperative preparation with intravenous mannitol is mandatory, as the resulting hypotony ensures temporary vitreous deturgescence, enabling entry into anterior chamber. Here, vitreous cutter was first used to excise the pupillary membrane. It is then introduced almost vertically downwards via the surgical iridectomy, with the cutter facing the surgeon posteriorly. Once the zonules are adequately cut, the face of the vitreous cutter is slowly rotated anteriorly, all the while cutting anterior vitreous until it is visible behind the posterior capsule. Anterior hyaloid face is debulked and is deemed adequate when the surgeon is able to perform a primary posterior capsulotomy, as seen here, better in another case. Primary posterior capsulotomy also additionally renders the eye unicameral, achieved previously with the zonulectomy per se via the iridectomy. It is primary posterior capsulotomy which helps to identify completeness of the hyaloidectomy, essential for preventing recurrence. Endpoint is recognized when the AC deepens. In this case, the tube had to be resighted too, as it was rather anterior. If an iridectomy is not available, then a pars plana entry is undertaken 3.5 mm posterior to the limbus. as seen here in a case of primary angle closure glaucoma where aqueous misdirection occurred post-M glaucoma valve. Debulking of anterior hyaloid face is done first, following which AC deepens and the tube becomes visible in the AC. This is followed by zonulectomy and iridectomy at the opposite limbus via a posterior to anterior approach. A mark is made on the vitrector for guidance intraocularly. Zonulectomy is then done, followed by iridectomy as seen here. Pars plana wound and conjunctiva is closed with vicryl. Irido-Zonulo-Hyaloido-Vitrectomy is also a very useful procedure when aqueous misdirection occurs during filtration surgery intraoperatively. Seen here is non-deepening anterior chamber during combined filtration surgery, even after reinforced suturing of the phaco wound and scleral flap along with hard hydration. Vitrector is introduced through the ostium and iridectomy, and as soon as the zonules are cut, the anterior chamber starts to deepen. Vitrectomy is completed by doing a hyaloidectomy. All these were pseudophakic patients. If aqueous misdirection occurs in phakic eyes, then the lens has to be extracted first via the anterior route. We have not experienced any intraoperative or postoperative complications with the use of this technique, and it gives repeatable results, as seen here in several cases, with anterior chamber deepening peroperatively and staying deep in the postoperative period. None of the cases experienced a retinal break or detachment, nor was subluxation of the IOL seen. To conclude, Irido-Zonulo-Hyaloido-Vitrectomy leads to complete resolution of aqueous misdirection. It is a useful technique in the armamentarium of an anterior segment surgeon to manage medically recalcitrant aqueous misdirection syndrome, eliminating dependence on vitreoretinal procedures, its cost and scale.